Hi, I'm Dr. Brian Kaufman, a retired family doctor, a CLL patient myself, and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. And I'm going to be talking to you about some research, a paper that's entitled Real-World Treatment Outcomes with Chronic Lymphocytic Leukemia or Small Lymphocytic Lymphoma, CLL/SLL, for patients who are treated with frontline single-agent ibrutinib versus chemoimmunotherapy. Rubin Wang of Janssen Scientific Affairs led a group of investigators that presented their results at the large American Society of Clinical Oncology, or ASCO, annual meeting in Chicago in 2023. And let's start with the bottom line. One more time, more research is presented proving that targeted therapies, in this case ibrutinib, is significantly superior to chemoimmunotherapy in frontline treatment for patients with chronic lymphocytic leukemia or small lymphocytic lymphoma. What distinguishes this study from other studies is that it used an extremely large database of real-world insurance claims. So let's get into it. In the way of background, over the past 5 years or longer, there has been plenty of research, including a couple practice-changing clinical trials, Alliance 1041202 and ECOG-ACRIN, ACRIAN, and we provide links to those for you to look at, that demonstrated the dramatic superiority of ibrutinib over chemoimmunotherapy when used as a first-line therapy in just about all situations in CLL/SLL. It is now at a point where it is no longer ethical to use chemoimmunotherapy as a comparator to ibrutinib or any of the targeted therapies, as there would be no equipoise or balance in such trials. What was the method of this study, and who did they study? This huge retrospective study evaluated treatment outcomes among patients with CLL/SLL who were treated first line with either ibrutinib or chemoimmunotherapy. And how did they do it? They used U.S. insurance claims data from a large payer data set derived from over 150 private insurers, and that covered more than 140 million insured individuals between 2015 and 2022. What were the results? A total of 3,570 first-line ibrutinib and 2,391 chemoimmunotherapy patients were included in this data set. Those are huge numbers. You could never get that in a clinical trial. The median age for the ibrutinib group was 68 versus 64 in the chemo group. 63% in the ibrutinib group were males, 66% in the chemo group were males, so similar. The median follow-up was 26 months for ibrutinib, 31 months for chemo. Here's where we start to look at the results. 13 versus 26%, or double the number of patients, recorded a next treatment during the study period for ibrutinib or chemoimmunotherapy, respectively. So, in other words, 13% of the people on ibrutinib needed to have treatment during the study period beyond the ibrutinib, where 26%, more than a quarter of the patients getting chemo, had to move on to a second kind of therapy. At 1, 3, and 5 years since the index starting the treatment, the probabilities of not initiating therapy were at 1 year 92%, at 3 years 83%, and at 5 years 76% for the ibrutinib cohort. What about the chemo cohort? Those numbers were 88% at 1 year, 70% at 3 years, and 56% at 5 years. After controlling for baseline characteristics, the first-line ibrutinib patients were almost 40% less likely to initiate the next line of therapy during the study period. That's a hazard ratio of 0.61. So what are our conclusions? Once again, we learned that frontline single-agent ibrutinib was associated with significantly lower risks of advancing to another treatment compared to chemoimmunotherapy in this large insurance claim-based data set. The dramatic difference is reassuring, and it's nice to see these results are consistent across a huge real-world database, and they don't just happen in clinical trials. But I would argue we no longer need to prove the superiority of targeted agents such as ibrutinib over chemoimmunotherapy. It's already proven. Thankfully, more research is now moving on to study the best ways to combine and sequence these revolutionary therapies. We need more research comparing the different targeted therapies to each other, not to chemoimmunotherapy. If you want to take a look at the details in the actual ASCO abstract, we have that online for you. Thanks for your attention. Stay strong. We are all in this together.